welcome to ABA Inside Track, the podcast that's like reading in your car, but safer. I'm your host, Robert Perry Cruz, and with me as always are my fabulous co-hosts.
Hey, Rob, it's Diana.
And it's me, Jackie.
You know, folks, sometimes when we do this podcast about behavior analysis and behavior analytic research, I say, let's just record only for BCBAs, behavior analysts. That's it. I don't want anyone else on the show. I don't want to work with anyone. When I go share behavior analysis, I just want to tell everyone this is how it is. It's the only way to be, and go pound sand if you think differently. But, that's one of the reasons
I have. Good, because you don't really like to share your toys.
I don't want to share anything, but that's probably one of the reasons I haven't had a real job in over a decade at this point. So, we were talking.
They
and we
say
thought,
no man is an island,
nope,
except for Rob.
Except for me. And we were talking about it. We said, you know what? Maybe we should work on that, or I should work on that. Maybe we need to be more collaborative. And so, we talked with a speech and language pathologist, and that was pretty fun. And then I said, but no more. I don't want to talk to anybody else. No other professionals.
That was back in episode 171.
Yeah. But then, but Jackie and Diana said, we know a really great professor, clinician, practitioner in occupational therapy, and we think you should learn to collaborate with him. And I said, fine, I'll try. So no promises, everyone out there, but hopefully we'll have a nice collaborative discussion with Dr. Michael Roberts about how to best collaborate with an occupational therapist in your profession. So Michael, thank you for coming here. I don't know if I'm happy about this, as I said, but I'll try my best. But thank you.
I'll do what I can, but I will say I am really excited to talk about both occupational therapy and everyone's favorite Swedish pop band from the 70s. When I got that email from Jackie saying we're going to be talking about OT and ABBA, I was really excited.
Woo! That's right. We're gonna dancing
Jackie,
queen it up around here.
I was going to say, we called Jackie Dancing Queen around the office. And so I was really excited to finally get a chance to talk about two things that, are really exciting and a lot of people appreciate. So
I do have hard eyes for you, Michael Roberts.
Thank you. I appreciate that you decided to take a chance on me.
Well, mamma mia, let's get this thing started. So, Michael, you are an occupational therapist. You're a professor at Regis, which is where you and Jackie and Diana are all colleagues there. And we're very excited. I was playing a part, everyone out there, someone who hates collaboration. Unless you know me, as you probably have talked to me long enough to know, I just want to talk to myself. But we are excited to have a chance to talk about some of the research on collaborations between Swedish pop bands and occupational therapists, possibly behavior analysts as well. It's a three-way collab this week, I think. But before we get into some of our research articles, Michael, would you mind telling the audience a little bit about yourself, your background, and a fun collaboration anecdote, if you don't mind?
Okay. So yeah, I'm Michael Roberts, and I am an occupational therapist. I have been an occupational therapist since before it was cool, way back into the 1900s when Methuselah was a pup. My first job outside of school, and once I graduated from OT school, was doing rehabilitation with cancer patients at Spalding Rehab in Boston. And I've worked in a wide variety of settings, taught at several schools. Most recently, I'm the founding program director for the master's degree program in occupational therapy at Regis College. Very excited about that. Besides doing OT, I volunteer at the animal shelter nearby. I spent a day as an extra on an HBO series this summer, and I also played the part of Guildenstern in an outdoor production of Hamlet this summer. So you can imagine what if I don't do theater on a regular basis, my classes get a little bit out of hand. So it's good that I get that out of my system away from the classroom. Otherwise, it really gets squirrely.
You did say that when I brought this up. I was like, do you want to be on our podcast? You're like, everything's just finishing up, so maybe that would be a good thing for me for a creative outlet.
Exactly. Let me see. Favorite collaboration anecdotes. I think one of the things that was probably the most interesting collaboration that I did was very early on in my career. I was on my second level 2 fieldwork. So OTs do 2 12-week internships to be able to qualify to work as an OT. And I was doing my second one, and it was a locked adult psychiatric unit where I was running groups. And I got to run a group with another young gentleman. So it was myself, unmarried young guy in his early 20s, And my co-leader was a social work intern who was also a young guy in his early 20s, and we were running a group together with these clients. What group topic do you think would be most appropriate for two unmarried guys in their early 20s? That's right. We ran relationships group. If you have an issue or a question about relationships, who do you go to? Unmarried young guys in their 20s. So, but it was funny. It's on the face of it, you say that's not going to work at all. But what that taught me was to work to communicate more with the people with whom I'm collaborating, because we had to make sure we were on the same page, and he wasn't coming at it from a psychodynamic and I was coming at it from a functional group. We needed to make sure that we were on the same page. We needed to be explicit about what we were thinking and why we were going to be pursuing a particular approach or activity during the group. And we reflected before the groups and we reflected after the groups. And we did a lot of processing. And I learned that that's really the best way for me to collaborate with people, is to be intentional about your plans and your reasoning process beforehand, and then make sure you're communicating about it afterwards. So, and I think that's what generally works, is just more communication, articulate your goals, articulate your plans and your reasoning. That's where you're going to do the best. Where we run into trouble is where we kind of get into our own little silos, our own lane, and just try and run parallel groups. It doesn't really work. We need to make sure that we're all communicating. Otherwise, it's not going to go anywhere.
I hear you, Michael. That is one of, I think, the key problems is a lot of individuals communicating, but not necessarily in the way you were describing, with a plan, with discussion of reasoning, and then letting go of that control when it comes to treatment or running the group. It's just, we're all going to kind of we're going to follow the same plan, rather than let's each do our own plan next to each other or different hours of the day. And I think that's where there's a lot of challenges. Some of them I think are systemic to some of the systemic to the systems, no, systemic to some of the organizations. Some of them are just people are more comfortable when they don't have to describe what they're doing to other people or answer to other people in the collaborative way. So,
no, and I agree. And it takes practice too, because how often do we talk about why we're doing what we're doing when we're just working with other OTs or other ABA or other PTs? You know what you're doing. You're all working off the same language. You're all thinking the same. You're very similarly have the same philosophy. So you don't need to articulate. But it's when we're working collaboratively, that's when we have to put in that extra effort. Definitely.
Well, I'm excited. I think we're all excited to get to hear more about what an OT does. What is their background? Because I think that's something that, while all of our articles, spoiler alert, say you need to talk to, the OTs you're working with about their background. I feel like that's the first thing that everyone say. I don't have time for that. Let's get right into it. So we have this nice, quiet, peaceful time to do that. And then we'll also be talking about more nitty gritty, how to collaborate. So we've got 4 articles that we'll be discussing. And the first is Interprofessional Collaborative Practice Between Occupational Therapists and Behavior Analysts for Children with Autism by Whiting and Muirhead from Journal of Occupational Therapy, Schools and Early Intervention. And that was 2019. Collaboration Between Behavior Analysts and Occupational Therapists in Autism Service Provision, Bridging the Gap by Gasiewski, Weiss, Leaf, and Labowitz from Behavior Analysis in Practice 2021. Interprofessional Practice for Simultaneous Implementation of Merged Techniques from 3 Disciplines, OT, SLP, ABA, by White, Stokes, Simons, Longerbeam, Richardson, and Zinn from the Journal of Interprofessional Education and Practice 2018, a journal I did not know existed.
You don't know JIEP?
No, it's not. It sounds like right up our alley for today. Yes. And Applied Behavior Analysis, Autism and Occupational Therapy, A Search for Understanding by Welch and Palachko from the American Journal of Occupational Therapy.
Who knew you guys were talking about us, Michael?
2016.
Of course. What, you think we'd just be like bumping into each other in the halls of schools all over the country? And who's that? I don't know. Or do you think we're going in like elaborate dance fight routines like the Sharks and the Jets? Like, no, it's...
It does make me happy, though, that the research articles that we're going to talk about today came from both behavior analytic literature and occupational therapy literature, suggesting that both sides of the story really want to be besties.
I like that too.
Yes.
I also feel like the titles of these articles came from one magnetic poetry kit for ABA-OT collaboration.
Which only had the words occupational therapy and collaboration.
And they just combined them in different ways.
So, Michael, we've got our articles. We'll be coming back to them here or there, but I think having you is our biggest resource on the show.
Aww.
So, that's in a way easier than I expected it to. Sorry. So, I kind of want to start with some general kind of questions, like the Ask an OT kind of a moment. And I guess my first one is, what is an occupation? It took me, I would say I started in special education. It probably was 15 years before I actually looked up or someone told me what the occupation in occupational therapy was. I assumed it was like a job. It's like a pre-voc kind of thing? Yeah. I was very confused. And I didn't bother to ask because, I knew everything as a BCBA in my 20s. So why would I ask anybody, right?
Unmarried man in your 20s.
I was also unmarried at the time.
Yeah, asking questions at work. That's like using your blinker to change lanes. Like, who's going to come on? No, thank you for that question because, I love to spread the word about how wonderful and magical occupational therapy is. But yeah, it's not unusual as an OT to walk into somebody's room or somebody's hospital room or meet with a family and a child and they're like, occupational therapy? My child isn't working a shift at the mill. Like, I'm retired. I don't need occupation therapy anywhere. When we're talking about occupation, we're talking about meaningful, purposeful, goal-directed activities. We're talking about the things you want to do, need to do, and have to do, the things that make up your daily routine, your life in general. The things you do that uniquely define who you are. You go to a cocktail party, you're standing there, one hand in the pocket, one hand on the drink, and someone walks up and says, "Oh, hey, what do you do?" Why are they asking that question? Because they want to know the kind of person that you are. Because what we do, the ways that the activities that we choose, the occupations that we choose, really are an expression of who we uniquely are, how we see ourselves, our values, our beliefs. So as occupational therapists, we want to use those activities that are most meaningful to people as our evaluation, as our modalities, as our stock in trade. So for working with adults, it may be basic self-care things, but it may also be worksite analysis. Working with children, the primary occupation of children is play. So we want to use play as an intervention. So we want to make a lot of activities playful and engaging. That way the child is motivated to do it. We want to trade in meaning. We want to be able to figure out, what do you really want to be able to do? And we see that. You see yourself as an artist. And you broke your wrist, and you need to be able to rehabilitate that wrist. Am I going to have you do therapy and squeeze it 48 times? I don't think so. Am I going to have you do 38 exercises and go into wrist extension and ulnar deviation 14 times? No. I'm going to get your paint kit out, and I'm going to say, let's paint, because you're going to be motivated to do that. And so therefore, that's going to be the most powerful way to get you engaged and to get you to do the things that you need to do, because we're starting from what's most meaningful to you. So that's kind of the background, the underpinning philosophy for us.
So when it comes to kind of those philosophies, it really has to do a lot with motivation, engagement, the doing aspects. So we talked about occupation. Are there other? I know part of the collaboration literature is going to say, please don't use jargon. Please don't use your own jargon. However, I do think it is important, since it can be hard to not slip into jargon every now and again, to have a sense of the key terms of a field, because, not only does it allow you to know more about a field, but it can show respect if you're able to sort of speak the language, so to say. So are there other terms other than, say, like occupation, that you say, ooh, if someone used this and they weren't an OT, I'd know that they were my, going to be my work friend. Like they had the terms down. Are there good terms that we should know? And if so, what are they? What do they mean?
No, I think, again, because what we deal with is everyday life, there isn't as much jargon. We throw around terms like clinical reasoning, or we talk about terms like engagement and collaboration and goal-directed activities, meaning. So we use a lot of terms like that I think are just general terms that people talk about working in any kind of a team situation. Mm-hmm. Then again, there are some themes or terms that I think are getting more traction in our profession, and we use several of them as curricular threads in our program. We talk about being occupation-based. And that means I want to focus and always be moving my client and moving my interventions and my assessments toward engagement and involvement and utilization of occupation, of meaningful activities. Can I make a splint? Yes. Can I give you an exercise program? Sure. Can I reduce edema with retrograde massage? Absolutely. But really, that should always be in the service to getting someone to engage in occupation, to get occupational performance, occupational engagement, social participation, whatever it is that you're trying to work on with that particular client. We talk about being client-centered. And that means we're going to be focusing on what are the client's goals, what do they want to be able to achieve, and how do we help them do that? Client autonomy is a huge core value and belief for occupational therapy. And so I have test questions where we'll ask the students, here's all the different things you could do with this client, but the client wants to do this. What do? You do what the client wants to do. Yes, you could come up with a splinting plan. You could build them a different wheelchair. You could come up with a whole bunch of sensory integrative processes and programs. But if what the client really wants to do is play in a certain way or be able to have fun on the playground with adaptations, that's what needs to be our focus. We need to focus on what the client wants to do, be client-centered. We need to be evidence-based. We've been pushing on this for about 20 years now. It's really been a push. We teach courses that are evidence-based. Again, it's threads in our curricula now. If you read the mission for the American Occupational Therapy Association, the mission for our profession, we talk about being science-driven and evidence-based. That's in the first few words of our mission statement as a profession. And we also look to talk about our clinical reasoning. And that may take a number of different forms: procedural and interactive and narrative reasoning, procedural reasoning, scientific reasoning. We talk about context quite a bit and the role of the environment, because we're always looking at our clients and saying the actual performance of tasks is often a construct of the person, what they bring, the environment, what the contextual challenges and setting for the activity is, and then the nature of the activity itself, the occupation itself. We also like to celebrate diversity. I don't know. I will admit I do not know exactly the demographic breakdown for ABA, but in OT we are still about a 90% female profession. So, white guy, I represent diversity in my profession, and that's just absurd. But the thing is, our population, we're always looking, we have a great deal of respect for the wide diversity of our population. We want to make sure that we take into consideration however somebody wants to live their life. We need to understand what that means for them in their community, in their social circle, and we need to be able to help facilitate their engagement with that. And I think those are the kind of the biggest terms that we throw around lately, the kind of the big themes. The thing, if you're going to a conference and you're listening to a keynote speech and you've got your bingo card, you would definitely have bingo by now.
Got it.
So, I have a quick question. So when I first started collaborating in public school, I was in an IEP meeting and the occupational therapy used the word sensory diet, and I had no idea what it meant. And I was like, we don't work in the lunchroom. And then everyone in the entire IEP meeting giggled. And I was like, what? I don't know what you mean. Can you tell the audience kind of what that means if they haven't heard it, or, just...
Yeah, no, we talk a lot about sensory input and sensory diet and sensory integration, sensory processing. We talk about that quite a bit. And it is part of what we do, definitely. And the whole idea of what you're willing to take in, what you're willing to understand, what you're willing to process. The sensory diet, I will admit, I've heard less and less of that term.
I have too. Yeah, I have too. But
so I hear more people talking about sensory processing or sensory integration, and less so on sensory diet over the last few years. I think kind of getting away from that term. But what you're describing is something that should never happen, which is someone says, hey, sensory diet, and you say, you mean like textures, like crunchy? And people give you grief. And no, this is not about who has the inside and who knows the jargon, and that's really restrictive. That's not collaborative. So if somebody has a question, then you should be able to just, like, what does that mean? Because the more we get away, as you guys described, the more we get away from jargon and the more we're speaking similar language, if not exactly the same language, the better off we're all going to be.
Mm.
And there's going to be terminology you hear in ABA, there's going to be terminology you hear in OT, and there's going to be a lot of overlap. But let's move toward that common ground where we're talking about the same thing, even if we are using slightly different terminology. But let's always err on the side of being generous in spirit and not saying, "Oh, I'm gonna giggle because you didn't understand what that particular term means."
And it wasn't even the OT that giggled. Everyone giggled. Like the parent giggled, the administrators giggled. Like literally, the OT looked at me, but everyone else giggled. I was like, well, gotta do some work, I guess. And it was a long time ago, I have to say.
Yeah. But I mean, no one can see me, but the whole time you were talking, I was nodding my head because I think that as far as the way that you're describing the mission for OT and some of the foci of OT, I always want to, thanks. Yeah, I know. There's a lot of overlap there, and particularly in the direction that we want to see behavior analysis heading, right? So we have the evidence-based thing down for sure. We're real good at that one, but an increased focus on self-autonomy for our clients and looking and placing what their interests and needs are first and foremost in our programming development is really critical in our field as well. And I think that there's a lot of overlap in these areas between our fields, but we might just talk about it in different ways and not recognize that there is that type of overlap.
Mm-hmm. Yeah, I mean,
good thing you're here.
Well, no, I think we're always going to be moving in the same direction. We're always going to be moving in the same general goal, because for either one of us, how do I know that my intervention was successful? I observe my client and I see what they do. And so same kind of thing. Like, did they do what they were supposed to do or not do what they were supposed to do? Are they doing what they want to do or not doing what they want to do? This isn't about, we don't expect to see a change in someone's complete blood count. We're not expecting to see someone's change in, their potassium levels. What we're looking for is, what does this person do? And is it, and what is the life that, the life that they're living and the activities that they're doing and the way that they're interacting with the world and people around them? Is that ideal? Is it optimal for them? And that's what both of us are looking at. So why can't we be helping each other over the obstacle in the Spartan race instead of, kicking each other when we're down?
So, Michael, when we talk about becoming an occupational therapist, I know that the research articles, and you probably have to refer to them every single day in your job, of having kind of guiding documents, and those leading to sort of like structured training programs. Can you sort of describe what the path of becoming an OT is? Because I'm guessing it's not waking up saying, you know what, OT, that's for me. I'm out to the schools or going to a hospital. I know there's a lot more that's going to be required, but I actually don't, other than some of the documents in the papers, don't know what that would be. Like, what is that training like? And how is it guided?
Yeah. For occupational therapy practitioners, at least in this country, you can be an occupational therapist or an occupational therapy assistant. There's 2 levels, and to make things, it's not that it's challenging or confusing, it's that we have multiple entry points for the profession, which actually works out really well, because then people in a variety of situations in their lives can still access the profession to go forward. So you can get an associate's degree or a bachelor's degree as an OT assistant. You can get a master's degree or a doctoral degree as an entry-level practitioner to be an OT. And where the profession has been pretty steady on voting to maintain those multiple points of entry. And I'd like to see that, because I think that's something that's going to help us. It's certainly not going to hurt our diversity by having multiple entry points. And I want to have more diversity in our profession, because the populations we serve are necessarily diverse. So why not have it in the classroom as well? So what you do is you apply to school. Often there's a variety of prerequisites, oftentimes including information around anatomy, neuroanatomy, physiology, but also things like psychology and sociology, statistics, because there's so many different things we do. Because we have to train people to have a holistic approach, they need to have a holistic background before they arrive to take classes. The coursework is going to take students from the beginning of life to the end of life. In fact, I had to warn my students this week that next week's topic is end of life and hospice. So then gave them permission. Just, I'm telling you now, if you need to get up and walk around, you need to get up and take a walk outside, you need to go outside and walk along and have birdies land on your shoulder and sigh in the sunshine, that's fine. do what you got to do because we'll be getting into some heavy stuff, but we can't talk about the whole person's life without talking about the beginnings and the ends. So we're going to look at developmental progression from birth all the way through older adulthood. We're going to look at both physical dysfunction, psychosocial dysfunction, sensory dysfunction, cognitive dysfunction, perceptual dysfunction, anything that could impact your capacity to do the things that you want to do. And we're going to be coming at it from a perspective of, hey, how can we help fix the situation? But we're also going to come at it and say, how can we help support and advocate? How can we advocate for a population? How can we advocate for universal access and universal design in the communities? How can we help people with community mobility? How can we help with adapting recreation? We need to train our students to look at basic things like, how is this child going to perform in a classroom? How are they going to feed themselves? How are they going to dress themselves? How are they going to engage in social interaction appropriately in the playground? We're going to be helping someone who had a hip replacement put their socks on again. Yeah, sure. But we're also looking at both work and rest and leisure and even sleep. Anything that's meaningful to you that you want to be able to do, we need to be able to train our students to help that person. So that means we're making splints. It means we're running groups. It means we are doing adapted recreation. Our students go and do adapted recreation, adapted skiing up in Vermont, up in New Hampshire, adapted skiing and snowboarding as field work. That's something we may need to be able to do. We have, and again, any role that is important, any way that you define who you are, and any component of that role, we need to train the students to be able to do that. So the curricula can be pretty expansive. You're generally doing 4 semesters, 5 semesters or so of courses for a master's degree, more for a doctoral degree. Everyone is doing observation and limited participation fieldwork during the curriculum. And then in order to practice, you need to work under the supervision of an occupational therapist in the community and do 2 12-week internships for occupational therapy and 2 8-week full-time internships as an OT assistant. And then for doctoral students, they have an additional doctoral experiential capstone type project that involves going out, developing a program and running it in the community and testing whether it works or not. Mm-hmm. So it is a combination of coursework where we try and be as active as we can and do as much learning by doing as we can. A lot of lab work as well as lectures. So we learn a lot about the history and philosophy of the profession. We learn about the constructivist and behavioral underpinnings of what we're doing, all the way through the psychological pieces, the anthropological pieces, all the way through the mechanics of the biomedical pieces that we need to do. It's a lot of information, and sometimes it does feel like we're putting 10 pounds of curriculum in a 5-pound bag. But if we teach multiple things at once and use modalities like problem-based learning, we can get the students to put in the extra work and gather that information. Like we tell our students, we can't teach you everything you're going to need to know for your whole career. All we can do is teach you how to think like an OT, and then release you into the wild. Because how are we going to prepare our students to work with someone who has had long-haul COVID for 10 years? We can't, because it's not happened yet. Right. It might happen, but we need to get them thinking like OTs, and then they'll be able to meet the needs of that person based on the values of our profession. So yes, master's degree or doctoral degree for entry level for occupational therapists, and then out into the world.
So, Michael, in that regard, unlike some fields, like I know in our field, I received my training to work with children with autism. And if I were going to say I do want to work with gerontological population, I would need to go find a mentor. I would not need to go back to school for it because the principles would be the same, but I would need to receive a lot of like specific training and feedback from another individual. But in terms of the coursework for occupational therapy, it sounds more like there's a broader base and then sort of like a problem solving mentality to all of that work, such that you're not like, well, I better do my internship on snowboarding because I'm just going to be a snowboarding OT instructor for the rest of time. Like you're really looking at problems that might not even exist using those, I don't want to say basic principles, but those broader principles. Is that
sure?
Is that kind of, am I conceptualizing it correctly?
That's absolutely it. I like to say that our students after graduation are like a Roman candle, the little fireworks, like they just go off in every direction. Because, but they all start from the same. They all get the same degree, and then our students have gone out and worked from our little we teach them the same curriculum. We have no electives. We just have these. This is what we think OT is, and we're going to teach this to you, and then you go off and make it happen. And our students have gone on to work in acute neuro inpatient settings, acute hospitals, school systems, outpatient pediatric clinics. We just had somebody hired at Children's Hospital, number one children's hospital in the country here in Boston. We had our students go out and then they can work in adapted recreation. A student was recently hired at the Easter Seals and is doing adaptive equipment there. They all, hand clinics, inpatient, outpatient, VA hospitals doing mental health practice, just anything and everything. But that's a great thing about an investment in an OT degree is it creates a foundation from which you can build whatever magical castle you want to. And like you said, if there's certain professions where if you start studying, barn owls as an undergrad, you are stuck with barn owls for the rest of your life. That's it. Because that's what your doctoral work is going to be in, and that's going to be a research, and so you're going to be sick of barn owls.
Well,
but
luckily, they're fascinating. So.
They are fascinating. Yeah. They're really fascinating, but not after 30 years, maybe. I don't know. But if you find them fascinating for decades, then you're exactly who should be researching.
That's right.
Then it's a calling. But for us, so it's for us, you can bounce around in different settings and different practices. And yes, if you're going to do something that's dramatically different, like I've only worked in nursing homes, now I'm going to work in a school system. Definitely seek out a mentor and definitely get some additional help. But you don't have to, really. I have faculty members who, one of our faculty members has done physical dysfunction, has done adult mental health, has done, and also ran the department at a hospital school. Same degree I got.
Mm-hmm.
And I did all my work, in a variety of settings, but I worked in inpatient, outpatient, home care, long-term acute care hospitals, kinds of crazy stuff, and taught at 4 different schools. But we all got the same degree from the same school. It's a wild mix. I mean, our other faculty members, one went to the Navy and worked as an OT in the Navy, did pediatrics working with the families that are on bases and helping with the children of those families, doing pediatrics, and then went into literal combat zones and worked with people that were recovering from concussions from what they're experiencing on the battlefield and other trauma. And he was somebody who had a degree from the school we all share. And then my last faculty member, also an OT, was a circus performer before she came to OT. So she has a private practice called Circus for Survivors, where she uses circus arts as an intervention. So trapezes and juggling and everything else, because if that's meaningful to you, and that's something that's engaging, we use it. That's what we do in OT. And again, all got the same degree. All went to the same school, one stage or another. So, and we all end up doing a wide variety of things. So yeah, that's why we feel that we really need to teach you to think like an OT and, buy into the philosophy and the underpinnings about how we think and how we look at the world. And then if you take that and you go out into the world, then you're going to have the whole world open to you. You want to develop your own new practice, go out and do it. Hypnotherapy, hey, go crazy. Do what you got to do.
So, Michael, in that regard, I know, kind of one of the questions I wanted to ask was sort of what would be like some common OT activities? Is that sort of a stupid question in that regard? Because if I picked a BCBA out of a hat, especially like in Massachusetts, I could probably guess like, oh, okay, you work with children with autism, you train behavior technicians, you do some amount of discrete trial training, you teach requesting, you run a preference assessment. Like I could probably, just guess without hearing a single word about where you work. And I'd get like 60-70% of, I do that almost every single day. Is that would you say that's not the same, like a relevant question to ask an OT? Or are there some like common, like everybody starts with this assessment or everybody uses some modification of a procedure like X, Y, or Z?
Sure. There's standardized assessments that a lot of us like to use because they work really well. So, sensory profiles, school function assessments, the BOT, Peabody, TEL. We also use the FIM like they do in a lot of settings. Vodka, the Rivermead, the MVPT, the TVPS. There's a whole bunch of different assessments that are commonly used across the profession. And but generally we use them because they work. Like the Rivermead, I love. It's a behavioral memory test, and it tells you right when you're done what the best cueing strategy is for that person based on how well they did on the test. So it immediately translates to practice, which I love. And I think there can be commonalities within specific pieces of profession. So what low vision occupational therapists do, they test and they teach about acentric vision, and they talk about magnifiers and light, and they talk about strategies for moving around in the community, and there's a bunch of adaptations that they can use. And they have a bag of tricks that they use that are pretty common to their practice. OTs in the school system, it's changing over time. There used to be a lot more handwriting than there is now, but there's a lot of activities that they use, and now there's fidgets and weighted vests and shaving cream play, and there's a whole bunch of different things. There's a lot of similarities in adult physical dysfunction practice too. Like everybody that has lower extremity problems, you're going to get a hip kit, which is a series of adapted devices that help you put your socks and your pants on. So there are commonalities within particular areas of practice, but I don't know that there's one OT toolkit of 25 activities that if you just take that group of activities, you can go practice anywhere in the country. Mm-hmm. It depends on the population, depends on the setting that you're in. If you might say, I've been doing this the same way in rehabilitation settings, well, that isn't going to work in the school system. So that's, again, why we have to teach. If we want you to be prepared for anything, we need to get you to think like an OT rather than just have a series of recipe cards that you dig into.
Yeah. And that sounds pretty similar, because I think we would say the same thing. We don't just apply the same strategies across the board, but the process sounds quite similar, where you would start with initial assessment, interview, observation, identifying what are going to be those meaningful outcomes for that individual. And then from there, you have strategies based on that person's needs that are going to help you get them to that end goal.
Yeah, and I think that's something this is one of the things that I really love about our profession. What I find so fascinating about the profession and about teaching the profession also, and I think it's something that's similar for you folks as well, is you think about if you watch from a distance, and if you watched a silent movie of the interactions, you'd be like, he's helping somebody put their socks on,
right?
Or he's helping them paint pictures, helping them. Why does he have that guy with a stroke holding a bowl of muffin mix with his affected arm? Why is he doing that?
Mm-hmm.
And just like, what is going on there? So, but if you play the sound, and if you actually dig in, and if you heard like a play-by-play from the practitioner about what they're doing and why, what's actually going on is so much more complex and interesting. And there's so many layers to it, because I need to understand this unique client. I need to bring my understanding and what I understand about, for my evidence-based practice, it's based on my training, it's based on my expertise, it's based on my experience, but it's also based on the literature, the research, and the evidence. So I need to have that's going on in the back of my mind. It's helping me with why I'm doing what I'm doing. But I'm also making decisions as I go along about the procedure based on how the client's responding. But I'm also being intentional about my relationship with my client and how I'm interacting with them. So how I present myself, how I speak, how I sit, how I make eye contact, all that is going on too. So it becomes this symphony of so many different things that have to be working right to get an elegant solution for the client that works and looks simple from a distance. So I think both of our professions are that way, in that we both are thinking about how do we get this person to this level of performance. And there's so many different things I have to be working at the same time to be able to get that optimal outcome.
That was really beautiful.
It really was. I feel like tearing up a little bit.
Before we need to reach for the Kleenex boxes, or maybe because we're going to reach for our Kleenex boxes, let's take a little short break. And then when we come back, we'll continue our discussion about some potential barriers to collaboration. We'll be right back.
Do you want to be a BCBA?
Sure, we all do.
Now you can come to Regis College in Weston, Mass. to get your graduate degree.
Choose from any one of these courses.
Masters of Science in Applied Behavior Analysis.
Masters of Science in Special Education.
Dual degree in Special Ed and ABA.
Or be eligible for your postmaster's certificate.
You can complete your degree and be ready to sit for the exam in 2 years. And our 2017 grads had a 100% pass rate on the BACB exam.
Come enjoy practicum placement support, ethics mini handbooks, PhD-level professors, small class sizes, and a service trip to Iceland.
If interested, don't delay. Supplies are limited. Learn more at regiscollege.edu.
Again, that's www.regiscollege.edu, regiscollege.edu. One more time, www.regiscollege.edu.
See you there!
And we are back talking with Dr. Michael Roberts about collaboration between BCBAs or behavior analysts and occupational therapists. But before we continue our discussion, I want to make sure that everyone out there remembers ABA Inside Track is ACE approved. By listening to our episodes, you're able to earn 1 learning credit. All you need to do is listen to the episode, then go to our website, abainsidetrack.com/getceus, GET-CEUS, and enter in 2 secret code words. And the first one is Avalon, AVALON, whether it's King Arthur's mythical burial ground or the board game company, which is how I thought of it because that's what we were talking about before we started recording.
Oh, I thought you were talking about the bar in Boston.
It could also be the defunct nightclub in Boston, where we saw Fountains of Wayne, R.I.P. Adam Schlesinger. Can't see them anymore. Sorry, now I don't want to talk about code words or collaboration. So we took a break to stop crying.
We should just note that these are continuing education credits for BCBAs.
For BCBAs,
in case we have a mixed audience for this episode.
Yes. So, Avalon, which I will only pronounce that way. So I'm glad we started off with discussing the strengths of occupational therapy, the background of occupational therapy, because in terms of looking at the literature on collaboration, having a respect and an understanding of the other profession is a huge component of being able to collaborate. Now, we would typically, if we were collaborating, also then share what we like about ABA and all that. But since this is a podcast mainly for BCBAs to learn to collaborate with people who aren't BCBAs, we don't need to tell you how to collaborate with yourselves. So we're going to skip that part.
Or do we?
Or do we? I hope not. So we're going to skip that. And then we're going to talk about some of the other common barriers. And there's one that I think, well, there's a few, but I know one that I think might be good to bring up now. And Michael, you mentioned it, and it was in a lot of the articles. So I hope you don't take this question as me trying to be nasty or take a dig. But it was in a lot of the articles that I think a challenge many BCBAs have when working with OTs is a sense that there aren't as many evidence-based practice in occupational therapy. And I know even in like the Whiting article that you had shared, there was some discussion about maybe that's like a generational gap, or there are, just like, I mean, honestly, it's going to be in any field. There are individuals who sort of learned the research in grad school, and then they learned what worked for them. And that became what they considered evidence-based practice, where I think we'd all agree that that's a component of it, but there's an ongoing, dance you have to keep doing with the literature to make sure. That's
problematic in any field.
Yeah, so that's a problem in any field. But it was sort of mentioned as like that could be one of the barriers that many BCBAs are like, I don't know what you're talking about doesn't make sense, or I don't think that would count as evidence-based practice. And especially if you're a young BCBA, that might mean, so ethically I can't work with you and I can't collaborate with you because if I did so, I'd be breaking my own ethical code. Can you, from someone who's in the field, Michael, can you kind of share, is that a common concern that you've heard, that you've had? Are there evidence bases that we as BCBAs just like, we're not even paying attention to that evidence base, so we're just assuming something that doesn't exist?
Yeah, no. I mean, when we talk about, it's funny because I was looking at one of the articles, I think it was the Gasiewski et al., the collaboration between behavior analysts and occupational therapists, autism supervision, bridging the gap. I read one part of it, and it was, paragraph says, BCBAs tend to rely on more objective measures of progress and change and to emphasize data collection to a greater extent than OT practitioners. OT practitioners tend to emphasize outcomes and performances in a natural environment. I read that and I was like Duke of Wellington ready for Waterloo. I was like going to go in. Did you get that? It was call back to ABBA.
Yep. Nicely done.
Yeah, that should be one of the code words right there. It should be one. That's up to you guys. You do your thing. But I read that, I was like, what? But if I look at an article that says, here's the results that we got from this client. If I'm looking at a BCBA article, I'm looking at an ABA article, and I'm saying, and this has happened, Jackie and I, we've had this discussion where we're collaborating on a thesis project for a student. And I've looked at the data you've gotten, and I've said, this doesn't look like the data I get in my articles. Yeah, but this is what we're trying to study what happened with this particular client over time, and this is what our evidence typically looks like. And I was like, oh, that doesn't look like my evidence, but I see what you're doing there. For OT, when we say we're an evidence-based practitioner, I'm sure you tackle an OT somewhere around. Look for them. They're the ones smiling in a hospital, a school system, grocery store. Generally, if you see the smiling practitioner, that's the OT. And just tackle them and say, hey, are you an evidence-based practitioner? They're going to say, absolutely, I'm evidence-based. Because what we see as evidence-based practice is, yes, it's the literature, yes, it's the research, it's also your training, it's also your lived experience and your expertise as a practitioner. All of that flows in to inform the decision-making that you do as a practitioner with your clients, whether you're talking about determining assessments, determining evaluations, determining priorities for intervention. And you want to be able to always fall back and say, the reason I'm doing this is because, and be able to articulate your specific reasoning and say, this is why I'm doing it. And I know our students collaborated with ABA students on a project just this semester. And I was looking over the materials, I was talking to the students today, and there were times where students had to say, well, the reason why I think I should do this way is because, and pointed to a resource or an article or a piece of research and said, this is why, because this shows that this works. So that's why I'm doing it. Even though we might call it different things, or we might say or our evidence is different than your evidence, we're still falling back on how do we justify what we're doing? And what can we point to that says, this is why I have a very strong suspicion that what I'm going to do is going to work. And again, like you said, maybe it's a generational thing. Again, evidence-based practice has been much more of a push for us over the last 20 years than it was 30 years ago. Maybe you became an OT and I remember when they taught me back in 1917 how to make splints out of leather and knotted silk. And that's what I did. And it was good enough for me. And it was good enough for Truman. It's good enough for my kids. That's not how we do things anymore. Now we have to look. It's funny because it has been no more than a few hours since I talked about the specific research behind my decision-making process. I was talking to a prospective student who was talking about potentially applying to our OT program and wasn't sure what she wanted to do. And she was asking about, do I have to take the GRE exam? And I said, yes, for our program, because research that a friend of mine did showed a correlation between one portion of the GRE score and fieldwork performance scores. And because I see that is a correlation, then that gives me more information, more confidence in deciding which students will be successful in the program. And those are the only students I want to bring in. So it was based on research that a colleague did. So it looks like something, oh yeah, of course we do the GRE because it's a standardized test and it's admissions. No, but I specifically said it's because of this evidence. That's why I'm making this decision as a practitioner, where education is my practice. So we're doing things for a particular reason. We're pointing to the evidence that what we're doing is working or has a strong foundation and is expected to work, is expected to succeed. We may use different terminology, but we're talking about the same thing. There's no reason to get all submarine grinder hoagie on this. We're all talking about num-nums, right?
Footlongs.
Sure.
That's a subcategory, I think, then.
I like everything you just said. It reminds me of what I often talk to our students about, which is, and your field likely would fall into the same kind of arena, right? Where we pride ourselves on being a hard science, right? Because we are evidence-based. We take data, we use those data to make decisions for the benefit of the client. But at the same time, we are also a soft science because we can take data all day long, but it's not up to us at the end of the day to determine whether we have done our jobs. That's up to the client. And everything needs to tie back into the social validity, whether they feel that we've done a good job and served them in the way that they wanted to be served. And we could take data all day long, but if we haven't done that, we actually haven't done what we're supposed to do.
You show them their graph and you say, look at this graph. And then everyone says,
I don't care about your
that's
graph.
great. Well, this graph tells me I'm really happy.
But I am great.
Thank you.
That's what this graph means.
Yeah, no, I mean, again, as I'm sure you would agree, this all goes back to Kierkegaard, right?
Of course.
Danish philosopher, father of existentialism, said that truth is subjectivity. So what the person holds to be true, the more passion they hold that to be true, the more that is true for them. So yeah, it's ultimately, oh, look, we showed that there's a regression analysis. So it shows that we can demonstrate that 80% of the variability in burnout happens based on great, but
right,
the actual person in the lived environment, what is their experience?
What are you going to do for me? Yes.
Yeah, and that's why there's assessment. So Canadians, fantastic OTs, marvelous, really, really good at it, love them. Them, the Aussies, they're all fantastic. But in the Canadian occupational therapy model, their assessment that they use is they ask and observe the client performing activities of daily living and instrumental activities of daily living, meaning self-care and making their meals and cleaning up their house and taking care of their kids and their pets and whatever else it happens to be. But they also ask, how important or how relevant is this activity to you? So maybe you can't put your socks on. Maybe you haven't put your socks on since Nixon was relevant. Mm-hmm. And you don't care that you can't put your socks on. So there's no reason for me to spend all this time and energy and money and resources and time to try and get you to do that, because it's not what you care about. What you care about is being able to do something else. That's what I need to focus on. And that's one of the challenges, I think, for all of us is, I like to say in OT, we don't do to people, we do with people. So the result is not, did I hook you up to a machine that did things to your leg and now your leg is better? The key is, do you feel like you can do the things that you want to be able to do? Are you living the life that you want to live? Are you, what is your experience of your day in, day out lived existence? That's what is you're right. That's what our ultimate goal is. And that's the one metric we really should be using.
So Michael, I'd love to get your opinion, because you mentioned it very well. I think it kind of, one of your, favorite kind of anecdotes of collaboration. It's sort of in hearing you discuss the background for an occupational therapy student, and kind of in looking at the, what information the article shared on that process. Sometimes I wonder if some of the challenges that might occur between OTs and BCBAs comes from having such a broad kind of knowledge of principles that can be brought and used, if you ask many of us, anywhere, at any time. Certainly for me, it's like, what's your role as a BCBA? Well, I study the science of behavior. And since almost everything's behavior, I can do it all. I know that's, I can't do it all, but within limits, I can do it all. Whereas it sounds like a lot of this, the work that goes into being an occupational therapist is, these are the principles, these are the problem-solving models, this is the information you have. So, no matter the problem, you can probably do it all as well, right? Do you think some of the issue might be in, okay, OT, BCBA, you guys have to work together, and who has the right answer? Well, we both have the right answer, because we could do anything. And does that become kind of its own self-defeating prophecy? Is that sort of one of the reasons that we need to define roles on a team or improve our communication? Like, what are your thoughts?
I think you're right that we have, we can both look at a situation and say, oh, that's me.
Right.
Because, like you said, everything's behavior. What's not behavior that someone does? And for us, it's like, what's occupation, functional performance, occupational participation. It's everything you do all day that's important to you. That's everything. We have one of the most recent pushes in the profession, and this was actually a multiple choice question on one of my recent exams. Sex is an ADL. So sexual function is something that is very important to people. Talk to people that have had a spinal cord injury. Talk to people that have had traumatic brain injury, women that are breast cancer survivors. This is a necessary component of their lives. So we help with that as well. And you're like, gosh, if we do everything, but at the same time, we all have models of practice. And I think what's important with our models of practice is to say, yes, here's all the things we do. You look at the OT domain and framework, our domain and process, our framework, domain and process. Our 4th edition is out now. And it explains all the contexts we work on, all the activities we work on, all the components of a person. But at the same time, you're still drawing a line and saying, yes, we do all these things, but there are some things that we don't do. There's approaches we don't use. So number one, our models of practice are inclusive, yes, but they're not inclusive of absolutely everything. And that's a good thing. So let's stick to our models of practice, our concepts of the profession. Let's stay true to it so we don't just get away and we're not doing anything that's unique to our profession. That's number one. Number two, yeah, there's a lot of overlap in things that we do. Didn't get a chance to watch the U.S. men's national team last night play against Jamaica in their 1-1 draw. Would have much preferred to see Matt Turner in goal rather than Zach Steffen. That's just me. What do I know? I'm not there. But if you're watching a soccer match, you're watching a defender. Ball comes to them, they kick the ball. Midfielder, ball comes to them, they distribute, they kick the ball. Comes to the striker kicks the ball. The ball comes to the goalie kicks the ball. They're all kicking the ball, but they all have completely different roles, and they have their different responsibilities within the team. So yes, there's a lot of overlap in things that we do, but as long as we're all communicating and we're on the same page and have the same plan, and it's a shared plan that we have made explicit, then we're going to be okay. If you look at an American football team, everybody has a role to play when you go off tackle, right down to the guys that aren't really involved in the play out in the wide receivers. So, but everyone has to do their part and everyone has to be coordinated. Otherwise, the whole thing falls apart. And you talk about it ahead of time and say, here's what we're going to do, guys or gals. And then you go and do it. And then you find out, okay, what result did we get? What are we going to do differently this time? And how did that go? As long as we're still having those communications, we might have some overlap in things that we do, but we're still going to have different roles, different responsibilities within the team.
Mm-hmm.
That's good.
I think, Michael, I completely agree. I think one of the challenges that I know I sometimes face is either that the systems are not set up to support collaboration. It's, certainly in schools, it's, okay, now it's OT time, now it's speech time, now it's ABA time, and then it's the rest of your day. And hopefully somebody will put that all together for you. But it might be that you just get like 30 minutes here, 30 minutes there, 30 minutes there. Then you see the psychologist for 30 minutes. And then hopefully those 30 minutes will the kid will figure it out at some point, right? Or the student will figure it out at some point. Yeah. So I think that can be a real challenge. I know, when you're working with students, do you have advice in terms of, you're going to be out in a lot of places. These might be some good inroads for conversation. Because I think the last thing I'd want to do is try to collaborate by saying something like, oh, you're an OT. You all have the coolest ideas for like physical objects and cool fun play activities. So I'll make all the plans. You just come up with something fun to add in there. Sprinkle in some fun after. Like, I know if someone said that to me, I'd be like, it's sweet that you think I'm always have a fun idea, but at the same time, you're kind of degrading the lack of knowledge I also can bring to this conference. I'm not just the fun police, here. I'm
going to go ahead and on this chalkboard in the shaving cream, I'm going to draw the brachial plexus, and I'm going to go ahead and show how this is actually working the way it's working. But I'm going to do it in a fun way. Hook shaving cream tea. But that's that is part of it. Yeah. I mean, two general principles. Number one is learn a little bit of the lingo of the people that you're working with. And that is going to vary from setting to setting. I mean, the way that people talk, the way people write IEP goals is different than the way people write goals at a skilled nursing facility is different than they write contact notes in a psychiatric setting, or someone who's a driving rehab specialist writes to justify something. So things are definitely going to be different. We can have different language around that, but understand when a PT says something, what they mean. When a speech therapist says something, what they mean. When an ABA says something, what they mean. Understand a little bit of each other's lingo so that you understand each other's approach more effectively. And don't be afraid to share some of that lingo. So I don't mind talking about gait analysis, or I don't mind talking about follicular folds and wet vocal quality with speech therapists. Use some of that terminology because that helps establish a common ground. If you go to, so let's say that some sweet day we can all travel again. I would love to go back to Amalfi, beautiful coast in Italy. It's amazing, amazing food. You're right there at the ocean. It's glorious. The weather's always perfect. The people are wonderful. If I go staggering into a trattoria and I try and get some food, if I make an effort to use the local language, I'm going to get treated much better, and I'm going to be more welcomed than if I come walking in and announce loudly in a brash Boston accent that I better get myself some spaghetti and meatballs, mucho fasto, or otherwise there's going to be trouble. So, but if I go in and I'm going to make a mockery of the Italian language, trying to order some food or ask what time they're open, and they're going to recognize that, they're going to appreciate the effort. It's kind of the same way. If someone comes to me and asks about ADLs or asks about adaptations or gradation of an activity, that's going to have me say, oh, they understand what's unique about what I do. It's a matter of respect. That's one approach, I think, is just understand each other's lingo a little bit. Number two, I think, is let's not lose, keep your eyes on the prize. What is this all about ultimately? This is about the client. So everything, as long as we keep bringing it back to the client, and it's not about our butting heads in a group meeting or an IEP meeting, this is about what's good for the client. And as long as we demonstrate that we're always going to be focused on what the client wants, that's instantly common ground for all of us working with that person.
Yeah, I love the shared terminology. And I know you discussed some at the top of the show, Michael. And then there's also in the Waiting and Muirhead article that you'd shared, I think it's table 1 has like a whole little, it's like one of those little cheat sheets for like, how would I say this in ABA or how would I say this in OT? So that might be a good resource for folks.
Definitely check that out. And I think I really like that article. I know it's pretty recent, and they do a good job of saying, let's pull back the curtain and let's show what we're doing. Let's lift up the hood on this and talk about what's happening, rather than, we're not going to really gain anything by keeping our magical skills and magical language and tricks of the trade all to ourselves, and we're never going to share them unless we are going to benefit ourselves or benefit our profession. Again, that shouldn't be our attitude. Let's like when you say this, I mean that. Let's have those conversations. And you're right, that article is great for helping get us on the common ground and say, here's different places where, believe it or not, we're actually talking about the same thing. Or that. So let's seek out those opportunities. Let's do that.
I know another recommendation that they shared, and you'd mentioned, is one that you yourself found to be key to, I think, some good collaborative efforts in the past. Really is devoting the time to the process of reflecting, of kind of looking at the interventions and how they're individualized. Are we getting the results? Regardless of what our final data system is, are we seeing improvement for the client? Is that something that just are there settings that just do a good job with this? Because I feel that I've seen some that just they have these meetings, they're just meeting after meeting after meeting. But you don't necessarily leave those meetings feeling like anyone collaborated so much as just said their piece and then sat there quietly, especially with Zoom. They just hit mute and they're like, okay, I'm done now. I did my thing. Is that something that happens more in like a hospital setting, or is it just an endemic problem of nobody wants to pay for people to get together to collaborate, and so you're sort of left making it up as you go along?
No, it's certainly more convenient and easier to do in certain settings. It's easier for me to collaborate with the nursing department at our school because we're on the same hallway, literally. So it's easier for us to collaborate because we're in the same physical space. So yes, if we're all at the same, when I worked at Spalding Rehab in Boston, therapy desk, PTs, OT, speech at one side, and 10 feet that direction was the nursing station with the doctors, the physiatrists, the psychologists, the neuropsych, and we're all working. We could just call over to each other like, hey, Janet, what time are you going over to see Mr. Jones? Because I'm going to go in there and do an ADL in the morning. And okay, I'll make sure he has his pain meds beforehand. Okay, cool. And you have structures built in where once a week we get together and we talk about this stuff. So there are settings where it's naturally built in, and there's settings where it's a lot more challenging. So if you are an OT covering 4 different schools in a system, or you're covering a rural school district and there's stuff all over the place and this paucity of staffing to begin with, it's a lot more challenging. When I worked in home care, it required a lot more effort and a lot more time to actually get people to connect, because I'm literally driving 200 miles a day in my car from Lowell down to Dorchester, back out to Framingham, and then back into the city again. And meanwhile, I'm trying to call people on the phone and connect with people. We're very rarely meeting person to person. You had to spend a lot more time and had to be a lot more intentional about that. So yeah, there's certainly settings and structures that are more conducive to collaboration. But when we collaborate, we are co-labor. We are working together. It only works if we're working together. You can put people in the same space physically, But if you don't, as a team, value collaboration and recognize the unique contributions of each of the members of the team and value those contributions, then you're not gonna get the collaboration. You're not gonna get the best result. And you need to have those situations where the OT and the speech therapist and ABA and the teacher's aide and the teacher and the parent have some kind of communication, yes, but also have a shared understanding of the unique contributions each person brings and communicates about that. And part of getting to that is, again, being able to articulate, here's what I'm doing, this is why I'm doing it, this is the underpinning for my reasoning process about it. Doesn't it make sense? Yes, it all makes sense. And look, by each of us doing our little piece, we have somebody doing garnish, we have somebody doing meats, we have somebody doing the salads, we have somebody, expediting, and somebody yelling profanity in a British language. You put all that together and you end up with a fantastic restaurant and a delicious meal. But you don't get to that point if you aren't all communicating, collaborating, and understand that, I can trust that person to do this part so that I can focus on my part. But then we put everything together, it's better than it would have been. It's more than the whole is more than the part, more than some of the parts.
Some of the parts?
Yep.
Yeah, sure. Yep. Okay, let's go with that.
Yeah, and I think a lot of that's just about the attitude going into the collaborative process. So if everyone says, we're going to work together for the benefit of this client, it's going to be so great. I can't wait to see what your expertise is to bring to the table. That makes all the difference. And some cultures are already well established, I think, like the way you're describing the Spalding, just the location and how those collaborative processes can happen. Make that whole process easier. But even if you're not in that setting, you can, go into it with that attitude yourself, and that can help to change the culture where you work.
Yeah, and it starts with us in education, making it clear that the only way you're going to succeed is by collaborating with people. Every like I was saying this week, every practice setting you go into is going to be necessarily interdisciplinary. So you have to be prepared to work with other people. There are a variety of stakeholders for every client you're working with, whether it's their family, it's their kids, it's their doctor, their nurse, their teacher, whatever it happens to be. Yeah, there's a lot of that you need to have that cooperation and collaboration. So it starts with education. When you're a practitioner, you need to model that. And yeah, it takes more time. And yeah, it takes more direct effort, but it also pays off in the end because your clients do better. And then when you're a supervisor, you're a manager, model that collaboration and expect it and talk about it with the people that you're supervising in that setting and say, you need to be doing this. Why are you not working with this? Why isn't this happening? Let's move forward in this direction. Look for those. And so wherever you are in your career ladder, from student to educator, supervisee, supervisor, there's a role for you to play in building a more functional, a more effective, more productive system for all of us.
I know looking at, I know we're running low on time, so we can't really do like a deep dive into it, but I know the White 2018 article had kind of an interesting idea where they thought of think about yourself, your master's ABA student, your master's SLP student, your master's OT student, and then let's pick a couple terms. Let's say, okay, we can train everyone to be master of their field, but also kind of like serve as a para in the other, to sort of live the experience of some of the terminology that you might have in OT, you might have as an SLP, you might have as in ABA. It wasn't.
And then, sorry, I was just going to say the context of that article is they had a center where they had access to autistic clients, and they were all working together with one client.
Yeah, and so to some extent, on the one hand, it did seem like an interesting way, especially if you were starting out in a career, to kind of get experience using some of the terminology, some of the techniques that the other fields would use. I don't know if I see it as like an ongoing way that we could build collaboration in, but a kind of an interesting experiment in terms of, here's a way to make collaboration part of the curriculum potentially. I don't know. I mean, did anyone else have kind of thoughts on that one?
I will have a flaming hot take on this one. I wasn't a huge fan. I'm not going to lie to you. And that's because, I have worked on feeding and swallowing in collaboration with a speech therapist. And I could be taught to do certain things that are similar to what they're doing, but I don't have the training that underpins why they're doing it exactly that way. Mm-hmm. And so I can stand next to somebody's bed and have them and count to 10 while they do heel slides like a PT would. but am I going to do it the same way they would? Am I going to get the same results? Do I have the same underpinning, the same philosophical, same training, and all the same knowledge base, and know what to look for, and know when it's going well and when it's going poorly? No. So I think we should still be doing what we uniquely do well, or we should be following our professional underpinnings, our values, our beliefs. We should take pride in the expertise that we bring to these situations. And yeah, there are a lot of commonalities in some of the activities, but that doesn't mean that I should learn to do a little piece of ABA because I'm not going to do it as well as BCBA is going to do it.
Mm-hmm.
You're not going to be able to teach someone how to do toileting hygiene as well as I can, whether you want to or not. So those sorts of things, I would prefer that if it's a practice area unique to our profession, let's stick to it. I think there's other ways that we can understand and learn about the unique contributions without having to try and do it ourselves without the same level of service competency. I think that's more of an ethical issue.
Mm-hmm.
So I would prefer to have us just work alongside each other and recognize the unique contributions that we have. Like, wow, I see what you did with that person. That's not how I would have done it, but I see how you got that result, and that makes a lot of sense to me. And I'm going to learn something from that. And that's going to tweak how I do what I do, and it's also going to tweak how I work with the other people of the same profession.
I feel like I see what they were getting at with that article, but I definitely see the points that you're making. And I know for our field, what might be a more useful sort of interpretation of what they were doing there would be helping BCBAs identify what falls outside of our scope and when we should be seeking outside resource and collaboration with folks who are specifically trained in those areas.
Yeah.
Because we don't, like you said, Rob, we're like, that's behavior, like, let's work on it. But that's not always appropriate. And there's information related to overall developmental scope, which this came up in our SLP collaboration as well, that we don't get necessarily that training in, that we need to collaborate and work with others so that we have the background knowledge. So I think recognizing when it's appropriate for us to pull in additional resources would be like a good direction, similar to how that article was structured, but maybe different.
One thing that I think would be really helpful that I've found success with in the past is helping speech and language pathologists and OTs with data collection, right? Because we are like killers at data collection and measurement, and we can help with the sort of data collection that you might need while you're working on the skills that you are qualified to teach and work with, right? Because we know ourselves some data collection, right? and
no, that's definitely something that you guys had on. I definitely respect that. When we try and teach our students about writing objectives and writing goals, we talk about writing SMART goals that are time limited and specific and behavioral and measurable. And we want them, but that's more of a periodic thing that we're checking in and saying, okay, over the last week we saw this happen, or yes, we saw this competency, or yes, we saw this skill demonstrated at that level of expertise. But it isn't something where we are recording within each session specific data points. We might be observing and making changes as we go along. Like, I see this person's doing this more easily, so I'm going to grade the activity to hit that just right challenge. And I think that's kind of going back to terms that OTs speak, where, how do I make this as challenging, make it challenging enough that the person grows from it and develops from it, but is not so challenging that it's frustrating and impossible to reach. So how do I find that sweet spot? I'm making adjustments within the activity, within the treatment session that happens, but I'm not writing down that piece. So my data collection is more aggregate over time. It isn't within each particular session. So yeah.
It might need to be if you're, depending on where you're at, or it might not be, but that's one way that we can help when, you have the expertise and how to change the behavior that you're looking at, right? But we might have the more precise, objective data collection methods that may be needed for like an IEP or a court hearing or, whatever you're looking for.
Sure. Sure.
So we are going to move into our last section, the Dissemination Station. Oh, it's so different when you're in your basement doing it, Jackie.
I'm so sorry. In my basement.
No, it's fine.
It actually sounded great.
It sounded great. So
it was like the train was just arriving in the basement.
It's an underground train. So, Michael, when we talk about collaboration, we've talked about a lot of areas for BCBAs or OTs. It's a two-way street to engage in more collaboration. We talked about sharing terminology. We talked about looking at, problem-solving
we somehow
procedures.
skipped this point about sharing lunch, which is
written down here.
Specific recommendation.
I assumed that was going to be in Dissemination Station, the one we all said. That's the one we endorse.
Oh, I'm so
sharing
sorry.
lunch. It was totally in the paper. That's why I put it in the notes.
You had me at lunch.
So other than sharing lunch, Michael, what would you say, whether it's for your students or you think might be just kind of a good first step? If someone listens to this, they loved it, but it's been 3 weeks, they forgot some of the points. What's the one sticking point that you think if you start your collaboration with this mindset, this action, you're probably going to be able to make it work? Is there a one, or is that too simplistic when we're talking about something that can be complicated like collaboration?
We've talked about a bunch of different approaches and a bunch of different values that we need to have. I think that one of the things that's really necessary, I don't want to get all late Michael Jackson and talk about, starting with the man in the mirror. Yeah, I don't want to change musical genres. I should
sure.
Back. What I think makes a great stepping off point is actually starting with yourself and engaging in reflective practice and understanding and being intentional about what you do and why you do it so that you can articulate it. So then when you're meeting with someone else, you can say, well, the reason why I'm doing this is not because I saw this at a conference once and I thought that was cool. Or my professor says this is what we should do with this particular diagnosis, so therefore I'm doing it. But rather, engage in reflective practice, make sure that you're being evidence-based and you're constantly refreshing what you do and why you do it. And if you are reflecting frequently, then you are able to articulate your reasoning more easily. You're able to articulate your values, your beliefs, what you're focused on. And that way, that's already ready to share. You don't have to go and start the rice for the meal when someone else is showing up with Kung Pao chicken. You need to have it ready so that when everybody shows up, you're ready to go. So then when you're in a situation and the PT says, I think we should do this, and the ABA says, well, what about this? And speech says, what about that? And the teacher says, what about this? They all have reasons why they're doing what they're doing. Be reflective so that you can participate, be responsible about that. So start there and then just have that attitude of, I have to be collaborative because it's the best thing for my client. Mm-hmm. So start with that, follow that path, and we're on our way to a bright future.
I certainly hope so. And I guess kind of my last question, or what I think might be a fun summary, is, Michael, we've been grilling you for over an hour now about, how do we collaborate with you OTs? Now that you've done collaboration with your program and Jackie and Diana's program, so I bet you've gotten some data from the students as to things that they liked about that collaboration, and I bet you got some hot takes of what's up with those ABA folks that I was working with. You don't have to name names, you don't have to point anyone out, but is there one thing that you say, man, I kind of wish the ABA folks would do or say this a little differently when they're working with, that doesn't have to be your students, but with OTs? I bet that would go a long way in rebuilding any bridges that I think, a lot of these articles seem to start with the thesis of, man, these two groups hate each other.
It's so silly too. No, and it's funny because what I saw I had the students do a reflection piece, because again, reflective practice is necessary, professional skill. And so in reading their reflections, there were times where they started from, well, they wanted to do this and I wanted to do this. It always came back to, we talked about why we wanted to do it, and then we came to a shared picture of what needs to happen. And I thought this was a really valuable experience.
Yep.
So it's okay to start from where you're starting, and it's okay to have misperceptions as long as you don't hang on to them. We OTs, we love Velcro, but don't Velcro them to yourself. just make sure that they are free-flowing, because we can, there's plenty of stuff in here about, OTs, all they care about is sensory integration, and we're all carrying Jean Ayres flags and waving them around from pillar to post. It's not true. But if you look at the research that we have, the research shows, and there's even recent stuff in just the last few years, we're looking at the comprehensive review, systematic reviews of sensory integrative practice, and what we found is, yes, sensory integration works for kids who need it, as long as you stick to a specific protocol and you apply it the way it's supposed to be applied in the appropriate situation. You get results that we can point to and say, look, this works. But that doesn't mean, so yes, that's wonderful, but we're not all just focused exclusively on sensory integration and sensory processing. We are doing so many wild and wonderful things around the world. So yeah, let's not get hooked up on the things that we were fussing about years ago. Like nobody else is talking now about which team are you on from Twilight, because that was so long ago. That was like a pandemic ago. Nobody cares about that anymore. People used to rage about that stuff. Who cares? Put that stuff. Let's just focus on what's going on right now. The only thing we can live is the situation, the moment that we're in right now. Let's start from here and let's go forward with the right attitude, and then it won't matter about all these horror stories from the literature from 20 years ago, 10 years ago, 5 years ago. Doesn't matter. I understand it's part of the context, it's part of the world in which we're living, but each one of us, let's just let that aside. Let's focus on what's directly in front of us, and let's focus on where we're headed, not so much where we came from.
I'm definitely Team Robert Pattinson, whatever his name is in that
Edward.
movie. Is he Team Edward?
He's Team
I'm
Edward.
totally Team Edward.
See,
I actually didn't see it.
I was on his team, but only in the movie The Lighthouse.
Oh,
that movie was too weird for me.
It was weird, but big Willem Dafoe fan. So yeah, that was an interesting one. It was an interesting one.
I know
Fair
no
enough.
references, so I don't know what's going on.
I'm gonna let this beard go a little longer, and I'm gonna get a Willem Dafoe Lighthouse beard. I feel like I'm close. I'm so close.
So, Jackie, The Lighthouse was this really bizarre movie about people living in a lighthouse with a whole bunch of strange and wonderful things in their past that all play out, and just these terrible toxic relationships.
Oh, maybe
So
I'll watch it.
kind of like The Big Chill.
No, it's not at all like The Big Chill.
No, and the music is not half as good.
Okay, fair enough.
Okay.
Well, Dr. Michael Roberts, thank you so much for being on the show, for sharing so much of your time. I know that if folks wanted to hear more of your thoughts on occupational therapy, you have had a podcast as well, or some recordings that people can access.
I did have a podcast. I've let it slide recently. I've had to prioritize other things in my life, but no, the I Love OT podcast is, I'm sure it's still out there somewhere. Did a whole bunch of fun stuff with that. We talked about international practice. We talked about magic. We had a whole bunch of different crazy, wonderful things that we did. And even just some episodes where I just went through the job postings and talked about all the different ways you could become an OT and if you just look online, hey, look, here's all these great and amazing things you could do. There's plenty of good information out there. I still love OT. I just not actively doing the podcast right now.
I like that you had to preference that you still love OT. You're like, I have this podcast. I still love OT, though.
That's right. Just because I Love OT, the podcast, is not active right now does not mean that I do not love OT.
Mm-hmm. You really
Totally
do
fair.
love OT more than anyone I know.
I do. I was accused of evangelizing about OT by the dean recently.
I know. It was me telling her.
I don't dispute. I don't dispute that.
And Michael, if we have BCBAs out there, say, you know what, I want to ask a tough OT question. That Dr. Michael Roberts guy sounds like he loves OT, so I should start there.
Or I want to learn about the program.
Or I want to learn about the program. I'm getting out of this ABA.
You can do both.
Are there that many BCBA-OTs?
Yeah.
There's only a few, but
I'm always surprised because I feel like it would be really good to know that, because like, talk about breadth of knowledge. You would know everything if you did both.
Yeah, no, we actually had one student who had been a BCBA and came to OT school in our collaborative practice activity. So they certainly had the background to be able to collaborate effectively. Yeah. So it's not unusual for our students to have that background and then jump over to OT.
Mm-hmm. Okay. Did you have contact information you wanted to share?
Best way to reach me is you can reach me through my work email. So michael.roberts@regiscollege.edu. That's the best way to reach me because I'm on email all the time as a program director and as a former fieldwork coordinator. I just can't get away from the email. So, and with my 12-month contract, I'm on all the time. If you have any questions, any ideas, that's the way to reach me. And yeah, tell me your horror stories about OT. Tell me what you love about OT. Tell me what else you think OT should stand for. It doesn't matter to me.
Once again, we want to say a big, big thank you to Dr. Michael Roberts for being on the show. We had a lot of fun talking about collaborating with occupational therapists. For some of you, that may not be something you have to do from day to day, but for a lot of BCBAs out there, you are working with a lot of different people, and knowing how to collaborate is not always a skill that you got in graduate school, and is one that is very important for both being a valued member of the team yourself, but really also in always thinking about what else is out there for the clients that we serve. So we hope you enjoyed this episode. Before we wrap up with our thanks to all of the other people who help us make the show, I want to get you that second secret code word. It is SHEEP, SHEEP. It's a woolly creature that walks around and eats grass. There was a movie about one named Sean. We get wool from them. They're great. Sheep. Well, we hope you enjoyed our episode of ABA Inside Track. We'd appreciate it if you subscribe to the show, left reviews on Apple Podcasts, Spotify, Stitcher, wherever you like to listen to podcasts. It really gives us a good sense of how people are enjoying the show, how we can improve the show. There are a couple other ways you can find us. We're on all the socials as ABA Inside Track. You can find our episodes posted with YouTube subtitling features on our ABA Inside Track YouTube page. You can go to our website, abainsidetrack.com, to find links to all of the articles that we discussed, our back catalog, as well as to purchase CEs for most of our episodes. And if you want even more ABA Inside Track goodness, you can join us on Patreon, patreon.com/ABA Inside Track, where for $5 a month, you can get episodes ahead of time, a week ahead of time, as well as access to our live tapings, some special Q&A events we have coming out, and discounts in our CE store. And if you want even more podcasts, say podcasts that last about 2 hours, talking about various books in the behavior analytic orbit, you can subscribe at our premium $10 level, where you can get access to all of our book club podcasts. We just finished, and by the time you're hearing this, you should be able to see on that feed our discussion of Nudge, the behavioral economics book. We talked for 2 hours about our thoughts on how nudging and behavioral economics in general relate to our field, and how it might help us as practitioners in working with individuals who need to make decisions, because we are all responsible for helping people make the best decisions that they can in our daily lives. So again, that's patreon.com/ABA Inside Track. And of course, you can always email us with ideas for episodes, or just to say hi at abainsidetrack@gmail.com. Once again, big thanks to our guest, Dr. Michael Roberts. Thanks to Jackie and Diana. Thanks to Dr. Jim Carr for recording our intro and outro music, Kyle Sturry for our interstitial music, and Dan Thabit of the Podcast Doctors for his amazing editing work. We'll be back next week with another episode, but until then, keep responding. Bye!